Want to get things rolling. For those who don't know me, I'm Shelley Hall from Baylor, Dallas.
I'm Marisa, Cevasco. I'm one of the cardiac surgeons at Penn.
And I'm a bulldog about timeliness, and so I may be chasing down our speakers if we go over, and he knows it. I'm happy to start us off with the overview intro with a friend and colleague, Dr. Jaime Hernandez from Baylor Scott and White Temple.
Excellent. So happy to be here. It's an honor. We're just going to talk about concepts related to heart failure cardiac shock management. As we know, it's a complex disease entity in which, again, escalating doses of inotropes and vasoactives transition these patients to a hemometabolic state with a very high mortality. But at the end of the day, when we compared IMI shock and heart failure shock, the goal is the same, transitions to longitudinal well-being, whether it's heart replacement therapies, native heart survival, or a transition to a palliative care situation. I think identifying the endpoints and the transitions of these patients becomes very important. And we have a lot of work to be done in the field. At the moment, the majority of these patients are being identified late with hemometabolic heart failure shock, on mechanical ventilation, with end organ dysfunction, with biventricular profiles associated with multiple devices, and this cohort of patients will have the highest associated in-hospital mortality and the lowest associated native heart survival. So we're stuck with really high complex shock. Hence, it's important to integrate, coordinate from a geospatial perspective using standardized systems of care. And again, I think this session naturally connects well with what we're trying to do at Baylor. As we know, transfers require a common language for risk stratification. We know that transferring itself is a risk factor for increased mortality, and that common language now it's being delivered, hopefully through the work of the shock working group in the CSW modified definition of SCAI stations, in which we have objective markers for hypotension, hypoperfusion, treatment intensity, and now the app constantly evolves based on upcoming data. What we really want is to avoid being in these circumstances in which we meet the patients in the highest level of severity, SCAI stages with cardiac arrest, in which we go through multiple device iterations, and the majority of the times high mortality follows. So from a conceptual perspective, we're trying to translate what we know from the IMI shock world into a heart failure shock world, in which, again, the golden day becomes very important, not only from a device perspective or a profiling perspective, but from all the other interventions required. And the idea will be to avoid cardiac arrest, and cardiac arrest becomes a very important signal of mortality, whether it's in hospital, whether it's out of hospital, whether it's heart failure, IMI related. And I think the presence of cardiac arrest really pauses us in terms of what is the goal of our therapies. We can have multiple devices. We can go through all the armamentarium that we have in our hospitals, but really the idea will be to try to stabilize these patients or to provide early benefit versus salvage, which again, I think that's a key factor in terms of how we communicate with our reference centers, with our teams in our own center, and with our patients. And in order to get to that point of improving our survival in these patients, I think vascular safety, vascular excellence becomes very important. And when we're going to choose the different types of devices, having an intended transition, particularly with heart failure shock, becomes very important. Having a phenotypic responsiveness and an idea of what will be the possibility of heart recovery becomes important. So hence, for heart failure shock, we have stratified these patients into different cohorts, that de novo heart failure cardiac shock patients, or patients that have been previously identified with heart failure. And as you can see, different transitions occur in different phenotypes, particularly with the de novo aspect of heart failure. We have a higher proportion of patients having the possibility of native heart survival. So that becomes very important. I think sort of the ultimate test for cardiac shock centers becomes that the de novo heart failure patient presented with fulminant myocarditis, in which you need the whole team to provide expedited care with high-profile mechanical circulatory support. And also important from the heart failure space to understand that not only high-profile pumps, transvalvular or VA-ECMO, will be able to be actually instituted in different phenotypes, particularly the restrictive phenotypes, the amyloid patients, in which again, axillary counterpulsation or other non-transvalvular or non-VA-ECMO related platforms will be helpful. From a management standpoint, I think we have made a lot of efforts to trying to incorporate hemodynamics with clinical and imaging. I think defining cardiac shock specialists, irrespective whether you have APP, MD, DO, or a specialty in cardiology related to, if you're able to integrate the clinical hemodynamic and imaging picture and follow a series of steps to transition these patients, I think you can really take care of a really sick cohort and use that same platform to go through the different iterations of mechanical support. The idea will be to improve congestion, improve perfusion, resolve end organ dysfunction, and once we have hemodynamic goals with ambulation of the patient, education of their disease process and their transitions, continue with systematic weaning, ideally, and if it's not possible, go ahead and transition to heart replacement therapies. There's many aspects in the heart failure management space related to LV unloading solutions after VA-ECMO, since a lot of these patients will be transferred on VA-ECMO to our centers. I think what we are starting to identify as a signal of perhaps best outcomes is the fact that these patients can be now ambulatory, even on high-profile support. And the idea, not only from an ambulation perspective, but from an end organ decongestion perspective, becomes trying to identify if these patients really require right heart support after multimodality decongestion. And I think from a management perspective, it's a frontier that our group is trying to identify as we go. At the ideal situation, we want to put these patients in one single device, ambulating with the ability to actually have a conversation with the patients and transition them to whatever mechanistic, coronary, valvular, rhythm-related, and now pharmacomechanical aspect in the future to try to improve their towards native heart survival. Again, many other centers are identifying the value of high-profile transvalvular pumps with adequate flow, and Impella 5.5 alone, as you can see, will have a signal towards less mortality, meaning that direct escalation to the highest profile support on a situation of heart failure shock might be perhaps something that we need to study further. What we have done in our center is trying to really hemodynamic match these patients to try to prevent or identify a single ventricle issue, left-sided wise, and we have situations like this in which we have the same flows going in with a Impella 5.5 and a durable VAD, and having pretty much the same hemodynamics before and after surgery. This has led to having very good outcomes post-operatively, less bleeding, less time in the vent, and again, really, I think unboxing these longitudinal transitions is going to be the future for our teams caring for these patients requiring heart replacement or heart recovery. And just to conclude, I think cardiac shock as a program has to be incorporated in any vision of any advanced heart failure program, and has to incorporate all the key stakeholders, which involve interventional cardiologists, intensivists, cardiac surgeons, and of course, heart failure specialists as well. Thank you.
Okay, well, that was a great overview. Thank you very much, Dr. Hernandez. I think we're going to jump right into case number 1. Tissue is the issue, biopsy on VA-ECMO, presented by Dr. Nikolaos Diakos.
Thank you very much. So I'm going to be talking about biopsy on VA-ECMO. I would like to thank you for the invitation. Starting with my case. Nothing is moving. So this is a 65-year-old male, was transplanted 2 years prior to this presentation, and presents to the hospital with fever, flank pain, diagnosed with pyelonephritis, unremarkable CT abdomen pelvis. The patient was initiated on antibiotics, And he was kind of stable from a sepsis standpoint. When day 4, patient starts developing bilateral lower extremity weakness, reduced reflexes at the lower extremities. Stroke code activated, CTA head and neck and MRI of the brain is negative for hemorrhagic or ischemic stroke. And given the persistent and progression of the symptoms, patient undergoes an LP that shows normal white count but elevated protein, highly suggestive of Guillain-Barré syndrome. Neurology services consulted, the patient is started on IVIG. And due to progressive respiratory failure, day 7, the patient needs intubation while he's actively receiving treatment with IVIG for the Guillain-Barré. The patient is in the intensive care unit, stable hemodynamically from day 7 to 10, and then day 10, he starts developing worsening hypotension, and overnight needs De-Escalation of inotropes and vasopressors. During this escalation overnight, he's having a POCUS that shows reduced allograft function, which was new. The patient had probably 15, 20 days ago another echo that showed normal allograft function. So we have a newly reduced cardiac function. And the patient on the way, while he was in the ICU, has a bedside balloon pump placed. Due to worsening hemodynamic status, he's transferred to the cath lab with a goal to do a right left heart catheterization biopsy. Quickly sort the coronaries, nothing significant other than the significant vasoconstriction. The patient is obviously clamped down from the shock. And the right heart catheterization shows severe biventricular failure while he's on balloon pump, epinephrine of 7, norepi of 10, and vasopressin of 0.04. So now we have a patient on our table. He is having worsening biventricular failure, and we may have an idea what is happening, but we don't really know. We don't have a definitive diagnosis. And this is a patient that we would like to have an endomyocardial biopsy because he may be having AMR, he may have acute cellular rejection. There's a condition called Guillain-Barré induced cardiomyopathy. Of course, stress-induced cardiomyopathies in the differential are very low. So this is a patient that we would like to have tissue, but we're about to cannulate him on ECMO to give a big bolus of heparin. So what are we going to do? Every time we need to balance the diagnostic yield of our biopsy with the complication risk. In other words, what is our pretest probability to have a diagnostic biopsy that will help our management down the way? And then what is the chances of having a bad complication that will be even life-threatening? So what do the guidelines tell us to do? There's an expert consensus came out a few years ago, and also in conjunction with the older guidelines from 2007. They say when you have an acute onset of heart failure with hemodynamic compromise and you don't have a diagnosis, that's as far as etiology, that's a class 1 evidence B indication to go ahead and do the biopsy. Of course, if a patient has a high-grade AV block, unexplained arrhythmias, worsening hemodynamic status, refractory shock, that's another indication. And then class 2 indications that do not apply to our case is restrictive cardiomyopathy, immune checkpoint inhibitors cardiotoxicity, of course, transplant surveillance. So according to the guidelines, we would go ahead and do the biopsy. But are these guidelines built upon those sick patients, those patients that are on ECMO? And the answer is no. But then what is the data we have on patients on ECMO requiring biopsy? So there are 2 papers out there, one from 2021, that's a retrospective analysis. Patients on VA-ECMO plus acute heart failure were compared to acute heart failure without VA-ECMO versus selective biopsy. You see the numbers are really low over the time, so it's not that it's the most common thing to see. And as you see in the bar graphs here, with the red color, those are the VA-ECMO plus new acute heart failure undergoing biopsy. They have twice as much almost risk of major complication compared to the other groups. Of course, on the other hand, you do have much higher chances to get a histopathologic diagnosis. You see 78% versus 51 versus 46. The reason being is probably because your muscle is infiltrated with inflammatory cells, so it involves larger areas, so the chances of getting a diagnostic biopsy, they're higher in this population. Along the same lines, that's a retrospective analysis. Again, small group of patients, 47 patients from a tertiary ICU in France, acute heart failure on ECMO, unable to win ECMO, and then you do a biopsy and you increase, you increase the chances of getting a definitive myocarditis diagnosis to 55% from 13%, and treatment can be modified in 32% of the cases. So that tells us that biopsy can be very important in those cases. Of course, we have to acknowledge the high risk. And what do? Then I think we have to improve the procedural safety and then tailor the ECMO management so that we will be able to accommodate a biopsy in those patients. So improving procedural safety, most of you are familiar with fluoroscopy-guided biopsy, crossing the tricuspid valve, we're pointing into the interventricular septum, we're getting an angulated view, we make sure we're pointing to the septum before we take our biopsy. There's also ultrasound-guided biopsy. So you have your biotome that is crossing the tricuspid valve, you can see it in a 4-chamber view, and then you can directly see your biotome pointing towards the interventricular septum in a position that makes you more comfortable that you're not going to perforate the free wall of the RV. In my practice, and I have adapted in those very high-risk patients, like the hybrid approach. So pretty much I do both. So patient is on the table, one of the fellows or an echo tech comes in the room and gives us a 4-chamber view. So we're very sure that we're going to sample in the interventricular septum. And do we have any data supporting that? Yes. So this is a study that actually compared fluoroscopic biopsy with echo-guided biopsy, actually fluoroscopic-guided biopsy with combination, and they saw that in 35% of the cases, when you place your biotome with fluoroscopy, when you did echo immediately after, you had to change the position and reposition because you were in a better spot with echo compared to the fluoroscopy. So next, we're going to the ECMO management. This is the ELSO recommendations about anticoagulation. We're shooting for ACT of 180 to 220 or PDT 60 to 90. There is a meta-analysis of 7 studies, small numbers each study, but if you pull them together, you see that if you compare low-dose heparin versus full-dose heparin, you have less bleeding risks. And the thrombosis risk, I mean, you can see it's in favorable with of the full heparin. However, it doesn't reach statistical significance. So apparently you don't lose a loss in terms of thrombosis risk. And then this is another study that it is about 203 patients. They use no anticoagulation in the management of patients on ECMO, and they had fewer hemorrhagic complications, fewer transfusions. So it is possible to do it. Of course, we know we shouldn't be doing turn-down speed during the low heparinization period, or we shouldn't prolong it more than 24, 48 hours. But that, if we have a complication for the biopsy, would give you the time to resolve the complication and not compromise the patient. So back to our patient. This is the patient, of course, was cannulated on ECMO. We started treatment for rejection, and now I'm about to write history in an interventional conference. I'm going to show a histology slide. So take your cameras out. That's never going to happen again. Patient had AMR. Then we kind of tailored our therapy to antibody-mediated rejection. Treated with plasmapheresis, which, by the way, also helped with his Guillain-Barré, and it has to be a success story. A few weeks later, recovery of the cardiac function. Patient, of course, was trached for a while, then decannulated from trach and back home. So performing a biopsy in patients with ECMO, it increases the chances of complication. On the other hand, the biopsy can increase the rate of definitive diagnosis, and specifically in that population of ECMO that are very sick and they have larger area of myocardial involvement, you can yield a better diagnosis with them. I think changing our technique and sometimes combining fluoroscopic with echocardiographic approach can increase the safety of the procedure, and of course, consider low or no anticoagulation for a short period of time if it happens to have a complication, a perforation, or a bleed that you need to do that. Thank you.
Well, that was a great talk. I have one question. Do you do anything? Do you manipulate the flows on the ECMO circuit? Do you turn the flows down to fill the right side of the heart when you're doing the biopsy, or you don't think that matters?
Well, I don't, but that's not an unreasonable thought. Another way you can do is you can have the cannula lower instead of going all the way up to the IVC. Another way you can do it is that you can use the long sheath so that you don't have to struggle with the biotome every time going next to the cannula. So you use your long sheath, you deliver your sheath to the intraventricular septum, and then you do all your passes.
That's great. Thank you.
Great presentation. Have you done it with TEE? I mean, obviously, these patients are intubated.
No.
Okay.
But that's also a good thought.
Sorry, Doug Pham from Northwestern. Follow-up question to Marisa here in regards to, number one, your anticoagulation when you initiate the ECMO. And then it's sort of counterintuitive for me, and then I don't know if you feel the same way, is that when surgeons like us are in the OR and we're getting in trouble with a distended RV that's bleeding, we go on pump because it unloads the RV and it decreases the bleeding. So have you thought about, in addition to manipulating during the time of biopsy, if you do have bleeding, just crank up the ECMO, unload that RV some more, and try to reduce the RV pressure?
Yeah, of course. I mean, you kind of try to poke into an RV that has higher pressures. Of course, the chance of bleeding there much higher, But so to your point, so you think by reducing the flow, you should be loading the RV, right? You want to increase the flow, right?
Well, I assume you're loading the RV at the time of the biopsy, right? So you can stabilize the heart, distend it, get a good piece of tissue, and actually get better echo imaging, I assume. And then once you got your tissue, crank up the ECMO, unload that RV, and decrease your RV pressure.
Yeah, that's reasonable. Also, I haven't done it, but.
Thank you. This was a fascinating case, namely because of the word allograft, right? You're using in transplant, right? And so what's interesting is when you take a look at the initial right heart numbers, there's near equal diastolic equalization, right? And so I'm curious, how old was this allograft in this circumstance?
He was 2 years old.
2 years old, because one thing we worry about in patients with transplant over time, from a chronicity standpoint, is the development of a restrictive physiology, right? And so in this circumstance, because it's acute, on top of the fact that there's this Guillain-Barré, is to what extent, and this is always going to be the question, is how will the biopsy inform your decision-making to change your management? And in this circumstance, your worry was AMR, or very high-grade rejection. And so in that context, may I ask, at Texas Heart, have you ever done a left heart biopsy?
Well, I'm there 2 years. I haven't seen one. So I don't know before if they have done one. In this case, I don't think the patient had actually a normal hemodynamic assessment probably a month prior to that because it happened to be close to his annual. So he has his routine evaluation. He has an echo. Nothing was wrong with the graph. I think it was all acute. Now, we always want to know if it's AMR or ACR. Initially, we kind of treat for both until we get, but then you see you can tailor your treatment and towards AMR. So I think it was important to know in this patient the diagnosis.
And the reason I ask this is I'm currently in Seattle at the University of Washington. Prior to this, I was at MGH, and one of the risk with ECMO is really the bleeding risk, and dependent on whether it's a native heart versus a transplant heart. We have a greater permissiveness with biopsies on the right side, namely because post-transplant there should be quote-unquote more pericardial space. But what the protocol, and this is something to consider for programs, is if you're obligated anticoagulation, you potentially can do a left-sided biopsy, and therefore with the septum and increased LV wall thickness to reduce that. The other aspect here is if this was native heart, if your indication is, let's say, giant cell or eosinophilic, but particularly giant cell, one of the protocols we now use in Seattle is actually voltage-gated biopsies in the native heart. So you actually, in the EP lab, you can actually map an area of focus where there may be the source of your VT and therefore have less risk of biopsying the free wall.
Yeah, that's good. And I know there are reports about sarcoid. You can do gated and target yourself and get the sarcoid spot. Yeah, we have not done one.
I just kind of want to ask the panel, do you guys at your institutions measure like a pre and post biopsy RA pressure? I know at Tufts we kind of leave it in there for 5 minutes, and you know, I thought it's not really
Routinely or on ECMO? Routinely or on
like
ECMO?
post-transplants routine,
Oh,
not on
we
ECMO.
don't.
No. There's not really a pericardium there to kind of, you know, even if there's a bleed,
Yeah.
it's not going to build tamponade within like 5 minutes. And, you know,
Yeah.
how long do you leave it in? Like, has anyone
I mean, in our
actually found
institution,
tamponade?
in our institution, I don't know, I'm just old school, I think. I mean, I can do my 7 pieces in 90 seconds, and it's, the incidence of perforation is so low. Well, the incidence of symptomatic perforation, we know by biopsy results, when you get the little epicardial fat on your results. If you get liver tissue, then you know you're in trouble. But it's so low that I wouldn't add that routinely. Now, obviously, in high-risk situations like this, I think every little tiny piece of thing you can do, double with fluoro and imaging, or EP mapping, or measuring before and after, all those different things, I think just helps you decrease your risk.
Well, the thing with the ECMO also is I don't know what the RA number means, So, but I like also to fluoro at the end. I mean, you can see, the borders of the heart, and you can see. I mean, if you've seen a perforation and hemopericardium, I mean, you can tell that okay, there's an extra layer over there when you just fluoro at the end, or a cine store at the end.
Any last question before we move on? This is supposed to be audience participation, so by my lecture, it's going to be voluntold if it's not volunteered. So, nobody? All right, thank you. I've given a warning. So our next case is from Dr. Kapur, heart recovery and brain death with E-CPR.
So I changed the title, as you can tell. I think we had a lot of E-CPR today, so I thought I would shift gears a little bit today.
Oh, okay.
Talk about something different. This question's come up a few times in the meeting today, so I thought I would present this thought exercise as it relates to acute limb ischemia.
I was like, wow.
So basically, I think it's important to recognize acute limb ischemia leads to death, limb loss. These are the things we're mostly concerned about. Timing's critical. Irreversible damage after 6 hours of acute limb ischemia. Those are all the fasciotomies, vascular surgery walking around, the vascular fellow really pissed off at 3 in the morning. All the binders, all the things that we try to do to mitigate this condition. Highly morbid condition, 1-year mortality amputation rates between 16 to 42% and 11 to 37% respectively for ALI. Now, we've talked a lot about mechanical support. I think I've heard through multiple comments throughout the day, everyone's concerned about putting a device in when there's PVD. We've talked a little bit about doing Pham bypass. We've talked about VA-ECMO with distal perfusion. So I think it's pretty clear that limb ischemia is a contributing factor in our decision making. Shock Working Group just has this paper accepted at Journal Heart Lung Transplant, looking at 7,000 shock subjects we identified about 399 patients with physician diagnosed and adjudicated acute limb ischemia, about 9% in MI cardiogenic shock, 3% in heart failure cardiogenic shock. And of the ALI patients, 9.7% of those were STEMI cardiogenic shock. Now, when we look at the mechanical support devices in association with limb ischemia, prevalence of limb ischemia goes up stepwise based on the French size. The caliber is really a major dictator. It's interesting to note that even with no MCS, you're still seeing about anywhere from 1.2 to 3% limb ischemia. So massive vasopressors, constrictors, they themselves can lead to that sort of digital ischemia, which can be devastating for patients, especially in septic or mixed shock. When you look at balloon pump, Impella, then you go to ECMO, and this Impella is Impella CP only. Look at ECMO only, and then ECMO combined with balloon pump Impella. Now you're starting to get up into that range of about 10 to 20%. So critically important to recognize limb ischemia as a risk when you're using MCS. Now, the reason why this becomes important is when we look at the risk of mortality in the presence or absence of limb ischemia. If you have limb ischemia in a patient with cardiogenic shock, in-hospital mortality doubles. So what this means is that if we have a better strategy to identify, mitigate, and limit limb ischemia, it's very possible that we could be reducing those mortality rates by at least 10-15% and trying to get a lot of these patients in the right direction. When we looked at the multivariable analysis of mortality in shock, limb ischemia fell out at the top, along with renal replacement therapy, Sky Stage E, and then greater than 1 MCS device. And of course, greater than 1 MCS device and limb ischemia start to go hand in hand. This is a really nice paper from Journal of Vascular Surgery showing actually in cardiogenic shock, no ALI versus ALI, and looking at the money. And basically what you're looking at is total charges are doubled when a patient has cardiogenic shock with limb ischemia, and length of stay is a big driver there. So 18 days versus 9.8 days for cardiogenic shock with versus without limb ischemia. So what I wanted to show you was just some of the thought process. This kind of brings you into the cath lab with me and a lot of the fellows who've trained at Tufts. So right now, if you look at the different approaches to ALI management and cardiogenic shock with MCS, you're looking on the left at a paper that was published by Zoltan Turi many years ago about the concept of Pham bypass, taking a Pham donor and delivering to a Pham recipient sheath to get passive bypass. The middle illustration also shows that with an Impella CP in place, a 14 French sheath that looks like a Cook sheath, as opposed to the peel away, but then using the sidearm and then doing an ipsilateral antegrade approach. Again, passive bypass because you don't have a pump in the circuit. And then on the right is what you see more commonly with ECMO, which is active bypass using the ECMO circuit to drive blood into both legs, so getting bilateral antegrade. So I want to ask you, just we'll do a hands up. So how many feel that using a 14 French sheath with a 6 French antegrade should give you adequate blood flow down the leg to mitigate limb ischemia if limb ischemia has occurred? So how many think that's effective, 14 French with an antegrade? Okay, we're not going to do yoga today. All right, and then how about with ECMO? If you have a pump that's actually driving the flow, do you feel like that would be better? Okay, all right, so I see some heads nodding. So this has not been studied. This is a wide open space. This is actually the next R01 coming out of the lab, is looking at limb ischemia and ischemia reperfusion injury. So the efficacy of passive versus active bypass is an open question. So when I'm in the cath lab, this is something that I would probably do when Duck was around at Tufts, and we basically ask a question and then we go try to find the answer. So this is basically a patient that we cannulated, I think just a month ago, for VA-ECMO, and what we wanted to do was better understand what happens to the distal leg. So we're going to show you a couple of different conditions, but first I'll explain the setup. So basically there's your ECMO cannula. This arterial return cannula was occlusive. We knew that that was going to be occlusive in that condition, so we had a distal perfusion sheath set up in the left leg, which is where the ECMO cannula is placed. And we actually had a 6 French sheath that we were using for the coronary angiogram, and then if we needed to add an Impella. So in this condition, what we wanted to do was understand what happens to flow or pressure in the distal perfusion sheath. So we took an OpSense wire, just a pressure wire, placed it into the distal perfusion sheath, and have the sensor sitting about 4 centimeters distal to the DPC. So that should tell us what's going on in that occluded leg beyond the distal perfusion catheter. And what we're going to show you is condition 1, which is passive bypass. So this is a 6 French donor going to a 6 French donor going to a 6 French recipient. So from the right femoral, going through a very short circuit, 1 stopcock or 2 stopcocks there, and then going down the distal leg to see what happens to pressure. What we also did was we placed a near-infrared spectroscopy patch on the abdomen, so above any area of limb ischemia, and then one on the left calf, which we know is going to be the ischemic leg, to get a sense of what happens to tissue perfusion using near-infrared spectroscopy. So this is the baseline, and I think this is an interesting thought exercise. Since we were using OpSense, we were looking at a couple of different things here. So this is before we activated any bypass. You've got the distal pressure in the DPC on the left leg, which has the occlusive cannula. We're on VA-ECMO, so this is actually your radial artery pressure on VA-ECMO. So you've got 94 for your radial artery pressure, but your leg is seeing a pressure of 17 millimeters of mercury. So your PDPA ratio is 0.18. Okay, and this is on ECMO at 4 liters per minute. So that's limb ischemia. So now we go ahead and we do the 6 French donor to the 6 French to the left distal perfusion sheath. And so what you see here is that the PD pressure went from 17 up to 33. Your systemic pressure is 93. So your ratio is actually still only about 0.35, so that's suboptimal. Usually, especially for FFR in the coronary bed, we're looking for greater than 0.8. So this is still sitting around 0.35. So that's with a 6 French to 6 French passive bypass. So probably not sufficient. So then we went ahead and we were placing an Impella in this patient. So we use this donor sheet, which is the Impella peel away. Now you've got a higher, larger donor, and you're going through the same circuit into the 6 French. So who thinks that this is going to normalize pressure and NIRS in the leg? So we're going to see normalization with 14 versus 6 French. Okay. So still going through the stopcock, so I hear, and the tubing is quite short, but that's about as short as it's going to get, but you've still got the 2 stopcocks, right? Okay, so we're not sure. So when we look here, your left leg pressure went from 33 to 39, and so now you've got a ratio that's come up a little bit to 0.43, but still not really optimal at this point. So now we look at condition 3. I didn't have an image of it because we were moving a little quickly here. But this would essentially be hooking up the arterial return cannula to the DPC to basically look at what we'd call condition 3 active bypass. So now we go ahead on active bypass, and now your distal pressure is 78, your systemic pressure is 94, your PDPA is 0.83. So illustrating just the difference between using passive bypass versus active bypass when you're thinking about distal perfusion. So keep it in mind when you're operating and thinking and trying to figure out what's the best way if you've got someone with bilateral limb ischemia coming in. This patient actually was a 27-year-old with mixed shock who had been sitting in an outside hospital, and they called us once they developed digital ischemia on 4 vasopressors. So really one of the sort of extreme examples of vasoconstrictive induced limb ischemia before we even put the ECMO cannula in. Now what's interesting is what happened to the near-infrared spectroscopy readout. So this is the NIRS patch sitting on the abdomen, so as sort of a baseline readout. When you look at condition 2, which was the Impella activated right about here, you can see there was no change in the near-infrared on the left calf. So it tells us that we may be getting some blood flow down there, but we're not actually getting tissue perfusion of the skeletal muscle. But when you activate condition 3 and you're on ECMO, now you start to see the NIRS start to normalize. And in fact, the NIRS in the leg starts to go up above the NIRS patch on the abdomen, so a little bit of a hyperemic response when you first do this. But I think this is really meant for us to, as a thought process, to think about using more imaging modalities, more monitoring modalities, using NIRS, not only for the bicerebral that we talked about, but also using it as a monitor. Are you getting effective results when you're trying to do limb ischemia mitigation strategies? Now, when we look at the data, when we aggregate just this one patient's data, you can see here at baseline, radial pressure, distal limb pressure, NIRS, and the left calf. And so condition 1 was 6 French to 6 French, 14 French to 6 French, and then here on ECMO, you start to see things normalize, and that's just shown graphically here. So I think it's something to think about. I was called in recently for a patient who had balloon pump removed and then thromboembolized to both legs. The patient was actually improved hemodynamically from a cardiac perspective, but we were asked to put the patient on ECMO to essentially assist with bilateral leg perfusion. So we now affectionately call this at Tufts LEGMO, and this is actually something to think about. If you've got someone with pretty severe limb ischemia, you've got thromboembolic disease, that patient actually was being looked at for limb amputation, but ended up walking out of the hospital with both legs intact. So more to think about, and again, for the operators enclave, make sure you're operating and innovating every day you're doing cases. Thanks.
Well, I liked your pivot.
Yeah.
So, anybody have some questions? Oh, great. Yeah.
Great as usual, Navin. So I think my question is for the surgeons in the panel, and for those programs that ECMO is mainly run by surgeons and cannulation is done by surgeons. To your knowledge, do you routinely perform distal perfusion catheters? And do you ever do this under fluoroscopy? I think that's one of the discussions I've had with my colleagues is that this should be always done under fluoroscopy to make these type of assessments, which, as we know, will change outcomes dramatically. And it's also a timing issue. It's not uncommon that patients get cannulated and then overnight, and then a morning will be asked to put a distal perfusion catheter.
So from my standpoint, I try to avoid ECMO, but sometimes you can't. And I never use anything big. I use a 15 French cannula. I don't think you can use inotropes and an inodilator and manipulate the flows and medically manage the patient a lot of the time. Okay, every once in a while you're gonna have a very big patient, maybe I'll put a 17 in, but I've never used a 19 French. my go-to cannula is 1525 or 1527. It could still be occlusive, but my default is not to put in an SFA. Because even when I do put in an SFA, there is that dead zone between where the arterial cannula enters and where the SFA enters. And then that's always a risk for forming clot because it's an area of stasis. So that's one thing. But if I do put in an SFA, for a while we were using 8 French pediatric aortic cannulas. So we were borrowing them from the Children's Hospital, and we were doing them with fluoroscopy at the bedside. So again, I think give the patient a little time, let them warm up, try and vasodilate them. If sometimes they need fluid resuscitation, very rarely, but try and medically manage them to the point where maybe you can avoid putting in the distal perfusion cannula. Because I think that thing causes more problems than it always will solve. But sometimes it's unavoidable.
So in our program, 10, 15 years ago, we were routinely putting in 18 and 20 French cannulas for inflow. And then we had a lot of limb ischemia stuff. Now we've gone down to like 15, 17, like you guys have. For the vast majority of patients, that's inadequate flow. I'm lucky in our program that our surgical fellows actually are very good at wire scales and ultrasound and all that, because they spend a lot of time in the cath lab with our valve team and all that. So for our protocols, within 4 hours of putting somebody on ECMO, actually even sometimes at the time of placing the patient on ECMO, if the patient's stable enough once they initiate ECMO, is to put a DPC cannula in. Within 4 hours, if they can't get it in, we're either mobilizing the cath lab or we're looking to mobilize the OR to recannulate the patient centrally. And then even once they get that DPC in, everybody gets NIRS. We check ABIs on all the patients. And the patients were, we use a 5 French or 6 French wire bound so they don't kink off. But the patients we still get in trouble with are the kind of the obese patients where you think that DPC is in, but then it just kind of works its way out, and then next thing you know, you're bleeding in the leg.
I mean, the other thing that the surgeon has, which is a good tool, which sometimes we forget we have, is we can just sew a graft onto the leg. Yeah. And so worst comes to worst, if I don't want to centrally cannulate, if it's a petite woman, I don't like axe cannula or axe grafts very much. I feel like they just bleed a lot more for ECMO. Robust men, I'll be more likely to do axe ECMO if I need to, but we can always sew a graft onto the leg if they really have vascular disease.
So then may I ask, is when patients are, because of the concern always for limb ischemia, and as in Navin's case, patients who may have had limb ischemia previously, and so now you're at risk for reperfusion injury, is there any role for preemptively, before ECMO cannulation of a DPC, to avoid the technical issues associated with the occlusiveness of the cannula and to ensure that now you have flow?
So for the patients who are undergoing CPR, obviously you just have to get the patient on and you get the DPC afterwards. If they're quasi-stable, we'll try to get at least a wire in first, and then we got wire up and down, and then we get a cannulas in.
Yeah, we do the same thing. In this, in some of the E-CPR cases, if they're on Lucas, and it gives us enough time, and there's sizable enough vessels on ultrasound, we'll go ahead and get the DPC in. What I usually do sometimes is just place a micro wire, then do the cannulation, but at least the wire's in place, and then we'll place the DPC afterwards. But you don't need to get the sheath in, you just need to get the wire in place. But it really depends on the clinical scenario. If it's semi-elective, then we've got time. We usually put a DPC in. But I think this question about cannula size is critical. We know that the outcomes are no different between 15 French or 17 or 19 in terms of clinical outcomes from like mortality, et cetera. But the DPC question is still open. I think there's been questions of whether or not there's enough equipoise to do a randomized trial of DPC use or not. Many people say there's no equipoise because even between the two of you, you're split. One just says this is what we do and this is what we do. So that suggests there is potentially equipoise. But as the interventionists start to learn from the surgeons, I think it's really critical to get some data on this point.
So one of the things, I think the biggest problem occurs in ECMO patients, those who end up going to vasoplegia, where the coming out of pressors become difficult. And I don't know if there are protocols in place for those patients to actually go for central VA ECMO or not, because I don't see in many programs doing that. But there are a subset of patients who go on ECMO and have more inflammatory storm, unfortunately, and end up requiring more pressors sometimes, which actually I have realized are the ones who actually have more limb ischemia problem, despite putting the DPG. It doesn't work in that. So that's something I don't know if what we need to think about is that if vasoplegia is an issue with ECMO on those patients, should we start thinking of other strategy? And the second thing, I don't know, one of the surgeons brought up to me once is probably putting venous and arterial cannulas in different limbs because the circulation does get affected, putting in the same limb, but I don't see anybody thinking and talking about it when we're in the lab. We are most of the time putting in the same limb. I don't know what are your guys' thoughts about that.
I think the surgeons, we put them in opposite limbs. It's pretty standard across centers. Because also when we go on bypass, we usually cannulate the vein on the right side because it's a straight shot. So we're used to putting the vein on the right and we put the artery on the left, especially in E-CPR. We'll have, just like at Northwestern, we'll have 1 or 2 fellows working at the same time. So I have one fellow on one side, one fellow on the other to get the patient on for E-CPR situation. But in general, I do 2 different sides, yeah.
I think what's really key here for everybody is every single person has given you a different approach. At our program, it's very rare to be the CV surgeon. It's usually our intensive surgeons, our intensivists, which are trauma surgeons, or our interventional heart failure, not our interventionalists, but our interventional heart failure. And we have a very rigorous protocol. You've got an activator on both sides, so we tend to do vein on one, artery on the other, simultaneously working to get access for distal perfusion. But the absolute single variation with every person here means that nobody knows what's the best practice yet. So whatever you're doing out there might be the best practice. You don't know, right? You were gonna.
I was just going to mention, that my question has been building up after listening to Doug. So I was interested in looking at your NIRS, abdominal NIRS, and how can these be actually quite different perhaps with central versus peripheral cannulation, and perhaps in situations like Mohit is mentioning that perhaps we're not really supporting the end organs in the same way when you have states of vasoplegia. So I was just wondering, what are your thoughts on abdominal NIRS and organ dysfunction, renal replacement being so far away in the risk multivariate analysis that we had?
Yeah, if you look at the vascular surgery literature and you talk to the vascular surgeons, they don't actually necessarily always trust the NIRS. The NIRS can be very highly variable. It's light sensitive because it's essentially looking at light penetration into the skeletal muscle. So using NIRS is good if you're really comparing it to baseline. It's mostly optimized for cerebral monitoring during intraoperative procedures. So for ECMO, that's a very reasonable thing. We don't know anything about abdominal NIRS. We don't know anything even about peripheral NIRS. We're using it because you can see one-to-one changes when you're doing an intervention. But the use of NIRS, I think, is something that should grow if there's question, and even for monitoring, as Duck indicated, they're doing at Northwestern. We're also now doing at Tufts. North-South syndrome used by cerebral, limb ischemia, make sure you're monitoring abdominal versus leg compartment.
May I ask one last question? This is for Navin, and because I really want to say the word Poiseuille's equation again. because actually, Navin, I think a lot of what you've done for this field has been to reduce this according to specific quantitative variables, and I think that's critical, especially in an environment, as Shelley's pointing out, where there's a lot of stylistic, you're trying to bring data. And so in your example of the 6 French with the tubing, to what extent do you think there should be modification or consideration outside of restrictive anatomy of what the appropriate peripheral, the donor sheath should be, and the size, the caliber, as well as the length of that tubing for DPC?
Yeah, I think it's all being limited by the stopcock. So there are some high perfusion sidearm sheets. There's also sheets that have sensors built onto the end of them, so you can monitor pressure on the tip of the sensors. We're not using any of those in our ECMO environment. So we're unearthing questions that probably will lead to hopefully more innovations in the space. Yeah, but there's a lot of work to do in this space. Surgeons have had ECMO for a long time. I haven't seen much change. So now it's coming to the cath lab. We'll see a lot of change in the next 5 years.
Okay, it's my pleasure to introduce Dr. Shelley Hall, who will be discussing our 3rd case, LV unloading with ECMO as a bridge to myocardial recovery.
Thank you. So my case is data-free zone. As throughout the day, we've been walking deeper and deeper into the data-free swamp. And so this is really meant to be thought-provoking and discussing. So this is a case of a 27-year-old Hispanic gentleman. No past medical history, presented to an ED, chest pain for a couple of days. The previous day, he'd also gone to an ER. He didn't feel great with his fever, and he was told he had a respiratory virus and discharged. When we were called down to see him, you can see his vitals there. He's tachycardic with hypotension for a normal 27-year-old. Still an adequate pulse pressure differential. He's febrile. He doesn't look good, and I think that that's one of the keys, is he doesn't look good. He looks like he's in trouble. Very dyspneic, he's got rouse, he's got all the heart failure signs and symptoms that nobody listens to anymore. They just look at the labs, the EKG and the test, and then they go see the patient. But he doesn't have a good physical exam, as you can see there. So these are his labs, which is probably what you got called about. You can see he's hyponatremic, low bicarb, elevated creatinine. He's got a mild white count. As mentioned, who cares about high sensitivity troponin anymore? They're all positive. He's got a high SED rate, which if it comes back that quickly to be able to give you the phone call for your consult is impressive. Moderately elevated lactate, and they've already done a viral panel for you, okay? We know that usually is done later, it comes back later, although the viral panels are getting pretty sophisticated and more rapid since COVID. His EKG shows diffuse ST elevation, and his echo shows biventricular dysfunction with normal geometry and size of the chambers, and I think that that's important. And so you can see this is a typical representation of this patient category. So he doesn't look good, okay? So we've got a couple options. We've got all the toys. We're in a facility where we got all the toys. So how many would choose a balloon pump to support this gentleman? Okay. How many would do an Impella CP? How many would do a 5.5? Wow, okay. And how many would go to ECMO? Well, I know because the title of my talk, you're leaning towards those last two options, but I didn't put the obvious choice, which was medically address the patient first, right? He still has an adequate blood pressure. He's still got an adequate pulse pressure. So, getting hemodynamics, getting a swan in, starting him on probable inotrope, all of the usual things that we should be doing. And I did that on purpose because I know this is more device related, but don't forget that we still are medical physicians first, even though I love all the toys and I love putting them in. And the reason we're talking about this is what we're trying to avoid, right? Now, this is the most dreaded result of acute LV dysfunction, whether it be post-CPR, severe myocarditis, whatever. But once you've got that picture, and I've been there a few times before I could get devices in, you're done. I mean, putting devices in that is probably not going to go well. And this is obviously the worst part of it, but before this develops, it's going to be your pulmonary congestion, your hypoxia, and your RV failure. So this patient actually deteriorated very, very rapidly. We got him in the ICU, we got a swan in, but he went down the tubes very quickly, and we ended up doing bedside VA-ECMO. Right before that, you can see his pulse pressure is narrowing. Right after we put the VA-ECMO, he's got an adequate map, obviously a narrow pulse pressure because it's mostly ECMO flow, but he's still very tachycardic, more so than he was before the ECMO was placed. He's now intubated, his lungs are wet to the gills, his extremities are still cool, no palpable pulses, he's totally ECMO supported at this point. And his labs show worsening end organ function. Okay, his creatinine's rising, his lactate's a little bit better, so some people are like, oh, let's just ride this out. That's his blood gas at 100% FiO2. You've seen some cases already about you've maxed out oxygen support here. He's, as mentioned, wet to the gills, confirmed on chest x-ray, and that's his SWAN numbers, okay? And this is on full ECMO support. So we know that that's not a good scenario, right? We know that if you leave that patient that way, it's not going to have a good outcome. And if we are hoping for recovery, and this is a category of a patient we're really hoping for recovery, myocarditis is what we're assuming this is, then we want to do everything possible to promote LV recovery. And those hemodynamics are not going to promote LV recovery. And as mentioned, this was from a SIO, 8 years ago, 7 years ago. So we've known this a long time. If that LV gets distended, that's not going to recover. So we've got to decrease that distension. And we've all seen PV loops. This is the place of PV loops, and we all know what happens on ECMO, right? Afterload goes up, LV EDP rises, and LV myocardial consumption increases. Now, if we were lucky and just needed that little bit of support, 12 hours later that heart is beating well, maybe we could get by without unloading this actively mechanically. But usually myocarditis doesn't work that quickly in recovery. So there are lots of algorithms. This is just one example, but there's lots out there, and the reality is that create an algorithm and follow it, okay? Nobody's algorithm is correct. This was put out in LaRusso's publication a couple years ago about sort of how to think about where and how to choose your unloading tool, okay? So obviously my case was to talk about the Impella 5.5 as the unloading tool. So in this case, we did do Impella 5.5. We're a big Impella center. We tend to use mostly 5.5s as our bridging to transplant and our unloading in ECMO if we have the time. Obviously, when you're doing E-CPR bedside, you get that in and you can't get them to the OR. We've done a few CPs, but we've already talked extensively about all the complications with CPs, especially in small ventricles, and the unpredictable nature of the duration of recovery time this ventricle is going to need. So we tend to go with 5.5s when we can. So we put a 5.5 in this patient. Now he's got a fantastic map. He's less tachycardic. His lungs have cleared up, and ultimately it did its job. It unloaded him. But it's the management of these patients with an Impella 5.5 and an ECMO that I really want to talk about. And there are no data slides about how to do that. The ultimate thing here is you've got to say which device is in charge. Okay, which device does the body need most? And we started with this body needed the ECMO and just needed unloading. So you're not going to be running this Impella 5.5 at 4 liters of flow. You're going to be at a low P level, maybe P3, just enough to unload, improve those hemodynamics, decongest the lungs. But ultimately, you've heard that prolonged ECMO support is not a good scenario. The inflammatory cascade, this patient's already revved up inflammatory-wise, and it's ultimately going to matter of how did that RV do once you unloaded the LV, because remember that CVP was very poor. So you look at this patient, and the left-sided edema has resolved. The wedge is acceptable. The lungs are clear. And the CVP, while not completely normal, is certainly much, much better. And to me, that's an acceptable PAPI and CVP to wedge ratio to consider that I think this RV will be okay. So in this particular patient, we then transitioned the support from the VA-ECMO to the Impella 5.5, because obviously this is the hemodynamics on 2 devices, right? This heart is not normal. Serial echoes, all the usual stuff that you do in myocarditis. But to me, this showed that we probably are going to need some support for a bit, and I don't want it to be ECMO if I can avoid it. And so then you have to decide which device are you going to make in charge, and this is where you start to transition from the ECMO to the Impella 5.5. And that requires very clear communication among your team, because how many times will a nurse call for a low flow on the Impella to the night person who doesn't know anything about the case, and they're like, oh, you got it at P3, increase it to P7, the flows will be better, without understanding what each device is doing. So it requires very clear communication, very clear chart documentation, because that becomes your communication to your covering docs in the middle of the night. And slowly decrease your ECMO support, increase your Impella support, and hopefully decannulate. And that's what happened here. Very quickly cleared out his lungs, improved his hemodynamics, and we're able to transition to the 2 liters of ECMO flow or so and get him off the ECMO. And about a week later, on the Impella 5.5, his EF recovered and we were able to decannulate. So this is a representative case of why to choose the 5.5, okay? Is it appropriate in everybody? No. And I wanted to get experience from the panel and the audience about, when do you decide to use a 5.5 versus something else to vent your ECMO patients? Anybody in the panel or the audience? Yeah.
Is there any concern based on that echo that you showed about having, there was a lot of smoke?
That wasn't their echo. That was what we don't want to see. Yeah, because you're too late then. Yeah.
Or myocarditis, as you described, in a young patient, that would probably be like this is like the poster child for 5-5 in my opinion.
Correct.
So
So high likelihood of recovery would be one patient group, probably go to 5-5. What about what other groups would you consider 5-5? Anybody? Right, prolonged support with a bridge somewhere, right? Okay, where you can't do anything else. If you're going to go axillary, go big or go home, right? Any other cases?
So a couple of things to comment on. So the echo, all that smoke, that's kind of scary. I think vast majority of the time, even when we see that smoke, it's really not clot in there. And so I think putting an impella in an acute situation like that should be okay. The one scenario where I might not consider a 5-5 impella as sort of our go-to for that type of scenario, but the one scenario where we might consider something different is if we see a very whited out lungs, and I think that patient may need VA-ECMO or some lung support for a while. I actually may put a Protect dual and use both limbs as venous drainage, so that way you get your LV unloading, right, your PA unloading, your LV unloading while the heart recovers, and then the heart usually recovers faster than the lungs sometimes, and so that allows us to transition to VA-ECMO to VV-ECMO, and then until the patient's ready to extubate.
I think that's a great point. We tend to, as cardiology specialists, think about the heart and all the lungs will take care of themselves, that ancillary organ. But you're right, the heart usually we can stabilize pretty quickly, and then you're left with this messy ARDS-looking lungs, and very not uncommonly ended up adding a Protect or venous cannula, VAV, to support the lungs long after the heart's recovered.
Yeah, it just depends on the mechanism. If you're flowing, we see this a lot from transfers in, if someone's flowing 5 liters on ECMO, they can't eject. The lungs get whited out, they get ECMO lung. Or is it from a totally deranged mitral valve and they have wide open MR? I love the 5-5, we use it a lot, but the 5-5 is not going to fix that type of MR, and sometimes they need a direct LV vent. That's a surgical approach, but the Protect, that's a good option too to help increase unloading. But the 5-5, I think what was interesting, and I'd like to hear what other people think, is you show that the wedge went down from 32 to 18. But when we look back at our patient, and we actually looked at Columbia's data as well, and we're in the process of analyzing it, but we don't always see a reduction in the wedge or in the degree of MR with the addition of the 5-5. And I don't know what other people's experience is, but it doesn't unload, for instance. It doesn't look like when you put a HeartMate 3 in somebody, right? That's a totally different wedge that you get.
Yeah, and I think that's important.
We looked at MGH data also for MR, no reduction.
Yeah, and I've been asked multiple times, well, put the 5-5 in, reduce that MR, make it all better. And I'm like, I don't think that's going to happen. I think the message is not that the Impella 5-5 cures all evils, but that in the cases where you think you're going to need prolonged support, what you're trying to avoid in patients is device after device after device. So trying to choose the best device for the best patient at the right time. And there's a financial aspect to this, right? We hear all of these great cases of this to that, and 17 devices later, your hospital CFO is looking at you crazy. But also the complication rates with every device that you have to add and exchange and all that, your complications go up as well. So if you think that you've got a recovery situation or an exit situation, but it's going to need more than 48 hours of determining whether that's going to be possible, I think that is the niche for putting your 5-5 as your vent machine, because it gives you that potential for what I call intermediate temporary support to sort out all those variables of recovery versus bridge. I look at the hemodynamics, and I look at the oxygenation. Yeah, I think we get fooled with pulsatility. We always say we want a minimum of 10 millimeters of pulsatility as our, okay, we'll accept that. We get a lot of flat lines once you put them on ECMO, and that heart just goes, I'm done, thanks. And does that mean I should immediately vent the patient? Well, if their wedge is still 12 and their oxygenation is adequate, maybe I can do some other medical things, as mentioned, before throwing a second device in. Maybe they're inotrope responsive, and I can get that going, and maybe I can correct the acidosis, and then they become more contractile. So I definitely want to emphasize, don't abandon your medical interventions to try and get pulsatility, ejection, volume removal, all of those things. You want to optimize the environment that this jeopardized heart is under. And I mean, so many times you'll hear of patients that were at somewhere for 2 or 3 days, and you look at their laboratory values, and their hypocalcemia was never corrected, or their acidosis was never corrected, when there were methods to do that. And once you did that, upon arrival to your ICU, you had a whole different, you were able to wean the pressors off, and they've got contractility. And so definitely don't forget the medical interventions.
This was a great case. In my institution, I typically, if I see this patient, if there's not that much of an oxygenation issue, if the RV looks fine or the hemodynamics doesn't suggest RV failure, we typically do 5-5 first. And obviously, no one knows what's the right answer. How do you decide in someone that doesn't have RV failure and no oxygenation issue, how do you decide on ECMO versus 5-5? And I know you raised that question in the beginning.
Yeah, so typically it's the acuity of the patient. If they need a bedside intervention, it's ECMO. We're a big ECMO center. We're ECMO, almost ECMO happy now, especially E-CPR happy. I'm kind of like going, whoa, whoa. I like run to the codes and kind of block my ECMO colleagues and go, let's take a breath, let's determine, where are we going to go with this patient, what's his exit strategy, all that kind of stuff. So we're very, very aggressive with E-CPR, and there's definitely been some cases where I'm going, you probably shouldn't have done that. If we're in a semi-quasitive, sick but stable enough state to go to the OR, then the Impella 5.5 is nice if the RV is okay. The problem is, it's a lot of these people we don't know. And so one of the things that's touted a lot, and we got to face the fact, ECMO's cheap, Impella's expensive. And so there's a lot of push by a lot of people, and I don't necessarily agree with it all the time, that if they're really sick, do the ECMO rather than commit to an Impella until you know more. And I'm a big Impella lover. I love the 5.5s. I think they give great support. So if I have time to do it, because we do it with a vascular surgeon, we can usually get that set up pretty quickly if we need to. One last question, so we can stay.
That same question, if you already have an Impella, how much do you care about pulsatility?
Right. Well, if you've got an Impella, are you talking about Impella alone or Impella with ECMO?
ECPella, you have Impella.
ECPella. I don't care about pulsatility. All that tells me is this heart is sick. Because if my device is unloading adequately, my swan is going to be telling me that, then the lack of pulsatility just tells me this heart's really bad. And your goal is, can I do anything to resume pulsatility and contractility of this heart, whether it's revascularization, if for this one myocarditis, do they need steroids and other therapies, do we need to do a biopsy, and figure out if we need to get more aggressive. I don't care about it if I'm on ECPella initially, but it is something that's telling me, it's giving me information that I need to figure out. So move on to the next one just for support time.
Okay, fantastic. So case number 4, post-transplant acute cardiogenic shock, Dr. Ali Nasir. Did I say it right? I apologize.
Oh, did they mix up? The next is after me?
Yeah, after you was post-transplant.
Yeah, it has Ali after me, but we can switch it if they've got these slides up. Okay. Ali doesn't have your slides.
Just to clarify, so Ali Nasir couldn't make it from UCLA.
Oh, okay.
Yeah, he had a family illness. So Mohit, we'll have you go ahead and continue. Thank you.
I can present his slides too.
Okay.
All right, I'm going to try to wrap up this escalation and de-escalation with the case in 7 minutes. I'm from University of Oklahoma, and thank you for this invitation. I have no disclosures. So this is a 25-year-old gentleman we recently saw, actually, who presented with worsening shortness of breath, had acute heart failure exacerbation, bilateral edema, fatigue. He actually was diagnosed with heart failure not a long time back, about a few months back. And then he had a PE 2 months back. And he is enjoying his life, didn't see a doctor, was given some medication, is a meth and cocaine abuser. So he said he takes these medications. He was on Lasix, some GDMT and Eliquis, and he says he was taking it. He comes in, we see him, my fellow sees him, and he's hypertensive. His blood pressure is 90/60. He's tachycardic, cold and clammy to touch, has bilateral crackles and edema. Lab shows his creatinine is 1.2. He has some signs of congestion. Liver function was elevated. Lactic acid is 3.1. Troponin is 44. BNP was elevated. EKG shows some ST depressions, some non-specific changes. They call me, I tell them, okay, well, let's bring him to the lab, do a right heart cath, figure out where we stand. At the same time, oops, what happened there? Let me go back and play this echo. So we do an echo first, since he was in the ER and we were able to do it. And we see that basically he does have very dilated LV, about 7.5 centimeter, and he has this valvular regurgitations, both mitral and aortic. I take him to the lab, not sure what to do over here still. I just shoot his coronary just because of those ST depressions. Coronaries were fine as expected in a 25-year-old. And these were a right heart cath finding. Not terrible, CVP still 12, PA pressures, mean P of 38. Wedge was 28, his V wave is over there with 40, I mean, clearly seen V waves. Index is 1.5, 1.8. Now the MCS option over here is very limited with AI and MR both. So I end up putting a balloon pump. He's 25, it's still 90/60. I'm like, okay, let's just put a balloon pump, call the cardiothoracic surgeon. This might be the best option for him to take him to the OR and try to do the surgery if we can optimize in the next 24 hours. So he does get some diuresis in the next 24 to 48 hours and then actually go for surgery or 2 days later. And they found that he had a ruptured caudal attachment to his anterior mitral leaflet, and he also had a redundant, actually a bicuspid aortic valve. So they put a mechanical valve considering his age of 25, of 21 millimeter, and then repaired his mitral valve with neocorday, did L-free stitch, and put an annuloplasty ring there. They tried to take him off pump, and this is how the heart starts looking over there. And they call me in the OR to just think about what to do next. Well, his LV function now is 10 to 15% after the surgery, and he is in biventricular failure. Basically, the LV looks bad. With this mechanical valve, we did leave the balloon pump still there. The options now starts is, what do we do next? I don't know if his option is limited with the mechanical valve in place. You have a mechanical valve already there now. I don't know, audience, any options with MCS? 5.5 is out, I guess. Mechanical valve is not there. So what are we going to do? I think the options are very limited here now. We basically think about VA-ECMO as the only option, and tandem heart is the other option. Well, we decided, you know what, he has a biventricular shock. Looks like that RV is not happy as well. And his CVP was 20 in the OR. So we decided, you know what, we are going to just place the VA-ECMO, and we left the balloon pump in place. He was on multiple pressors, and actually decided to put an LV vent. So he was still they were taken back to the OR, and we decided, you know what, we are going to put an LV vent apically by the surgeon. So we decided to put an LV vent over there, and this is something I think is important to this day and era, because now we are just not talking about ECMO. We are in the next level where we need to start thinking what are the options for LV vent percutaneously as well as surgically. And I think there was a great case scenario for that. We had a balloon pump in place, which again with the mechanical was not the best option, but we left in place. Impella, tandem heart, as some people brought it up, was thought about. But then there are other options which we can consider sometimes in cases like this when we have a mechanical valve in place and patients have biventricular dysfunction. Surgical approach includes putting an LV apex catheter LV cannula, which our patient got. He got actually a 32 French cannula in the apex. And we can also put left atrium venting using a right superior pulmonary vein. But you know these options also exist in cath lab, because now we can put some cannulas in pulmonary artery and connect to our ECMO circuits. I've seen that occasionally. I've not done personally. I don't know if anybody has experience with that, but I've seen it in talks, that you can try putting a pulmonary artery cannulas by percutaneous approach, especially the double lumen catheters, and try to unload the ventricle by that strategy in cases like this. This was the cannulation showing that basically he has a VA-ECMO with an LV apical cannula in place and a balloon pump as well in place. Day one, and he has a massive bleeding post-op. He got almost 10 units of PRBCs, multiple FFPs and cryo. His creatinine was 2.7, lactic acid went up to 5, hemoglobin was 5.6 actually, and the ALT was 2,673. Kept his support on, basically at this time, most importantly, making sure giving all the butter products, does not go into a vasoplegic shock. That was the most important thing at that time. But he turned around after 24 to 48 hours. He was oliguric, so we started CRRT early. Slowly started weaning his pressure, especially because he was getting so much of transfusion. We didn't want his CVPs to go up, so we started CRRT very early. His numbers started turning down on post-op day 2. Lactic acid was 3.1. ALT started improving a bit. Day 3 actually kept going down. He started coming off pressure, was just on dobutamine and some of epi. And we do daily echoes. This was the echo on day 4, which shows like his LV is recovering better. And RV looks dilated, but still better than what it was. So we decided after the day 4, his numbers were looking much better. Lactic acid cleared off, and his congestion profile was looking much better. We started weaning him off. And on day 5, ECMO was decannulated. We extubated him on day 7. We did leave the balloon pump till the end. I'm not sure it did a lot, but we did leave the balloon pump. On day 9, we removed that. He had a complicated course for 14 days, but he started peeing. And he was discharged on medical therapy and warfarin for his onyx valve. So he had a good outcome out of this, and he is following in clinic. So the question of what mechanical device, how to choose, how to escalate, I think there are a lot of things in this. It's not a clear-cut answer there, and it also has been talked before, it's very institution to institution driven. But one thing I do talk to my fellows is that you need to look at, first of all, what type of dysfunction are you working with? Is it LV dysfunction, RV dysfunction, or BIV dysfunction? That's the first thing you need to recognize before putting any kind of mechanical pumps. And then you need to recognize what type of hemodynamic deficit are you thinking about? Is it a person whose BMI is 49 and you're trying to put an Impella CP? Or is it a BMI of 24 and you're trying to put Impella CP? That does play a role because hemodynamic deficit does help in the amount of perfusion they receive. And then in patients with heart failure, I think initial clinical evaluation is important, and you have to categorize what phenotype of heart failure are you treating with. It's a valvular shock, is it a myocarditis shock, which also helps you in deciding what type of mechanical circulatory support you can use. You should have a daily parameters in your protocols and algorithms for shock management, where you're going to manage them first on inotrope pressors on daily basis, look at their lactic acid, congestion profile, and if they are worsening, then you need to act early and then look into whether they are having a biventricular dysfunction or an additional some other LV or dysfunction which is not supported enough, or RV dysfunction which may require an RV support device. I think this is the tip, very, very important to use hemodynamics in that regard and have a PA catheter in continuous management in patients with heart failure shock, which I think the current PAX trial will give us the answer for that, if the PA catheter can be very useful in these patients or not. So as I mentioned, I think after you put the pumps, I think it's important to manage their daily kidney function, liver functions, to look for congestion profile, manage their lactic acid for hypoperfusion. Neurological recovery is equally important, and also to look for their platelets and hemoglobin, because many of these pumps does cause hemolysis as well as thrombocytopenia. So I think in comparison to coming to once they are on pump, how do we start de-escalating? I think these all clinical parameters are the one which helps us decide that. We look at them on daily basis, they are improving as it was seen in our patient, then we can start slowly weaning them off. And within 24 to 48 hours, every program has different rules, rapid de-escalation versus slow de-escalation. If their numbers and profile keep continuing to improve, you can start decannulating and start taking the device off. If not, then probably it's the best time for patient to be transferred to a center which can have a VAD and transplant. So to summarize, early temporary MCA utilization can be life-saving in patients with heart failure shock. Appropriate temporary device selection depends upon the shock profile and the degree of hemodynamic compromise. Daily parameters are important for both escalation and de-escalation, including hemodynamic monitoring, imaging, laboratory and clinical parameters. And I think the shock team plays a very important role in this, in deciding and managing these patients and escalating and de-escalating at the right time. Thank you.
Any questions?
I have a question. In this case, did you consider central cannulation? Do you think that, and I wanted to hear people's opinion in terms of the effect of central versus peripheral and the need for venting. I mean, maybe central cannulation would have given you the opportunity to get away without venting here.
He actually did get central VA-ECMO.
Those
Those echo was in the lab with the central VA-ECMO's place, and his LVRV was still struggling.
I see.
So we decided to put an LV vent because of that reason.
I mean, I think we're probably thinking the same thing. Yeah. I mean, I think we probably, it was a really masterful save. And I think especially the mitral valve to repair that mitral valve, that was very nicely done. I might have taken a little different approach, and I probably would have, if I had a case like this, and I think we've had cases like this, I probably would have planned on an Impella 5.5. And also in a drug user, in our practice, we actually don't put mechanical valves in. But I think
so that was a good question. Aortic valve, 25-year-old drug abuser. Mechanical versus bioprosthetic was a big question at that time. That was one of the reasons our surgeon thought, because of his young age, again, he was not sure whether we'll take Coumadin or not. He was thinking of bioprosthetic, but he took a call that, you know what, I'm going to put a mechanical valve, and that might serve him better. So he put a mechanical onyx valve because it does require a lesser amount of anticoagulation, not in mitral. In aortic valve, we all know that you can actually get by with lesser INRs in that. So that was one of the reasons he put that.
Yeah, but that's exactly right. And the onyx valve would be the perfect one if you were obligated to put a mechanical valve in. But I think I would have planned on an upfront 5.5, and we passed the wire through the aortic valve, and then we put the aortic valve in. We do the mitral repair, the aortic valve replacement, and then you can just put the 5.5 in, and you come off bypass with the 5.5. And it actually provides biventricular support a lot of the time, and probably would have avoided, maybe, but possibly would have avoided central ECMO, the bleeding, certainly the bleeding, and the need for renal replacement, possibly.
So 5.5 with mechanical valve, that
no, you can't do that. That's what I'm saying.
That's what was the reason.
Yeah,
I think
yeah.
he did not use it. So.
Yeah, I think Marisa and I were looking at each other thinking the same thing. This is a nice case of it pays to be young, number one. In planning this case, you brought up a good point. The phenotype is important, right? In a patient who has valvular disease, and this is sort of chronic valvular disease, it's going to take that'll be a little bit more time to recover. So you got to really go in there thinking there's a longer term recovery that you need to do. And somebody who's an IV drug user as well, who may or may not take their Coumadin later on, I'm more inclined also then to use tissue valve. So the advantages there are now, A, you don't have to put them on anticoagulation immediately post-op. 2, you have an access to the LV to event the LV, put a 5.5 in afterwards. So I think your surgeon did a great job with that mitral valve. I think a lot of surgeons would have just replaced it and done double tissue or double mechanical, and then they're really in trouble. The other thought I had is if in a mechanical valve situation, the one danger though of any sort of ECMO and then adding extra venting on it is that aortic valve then remains shut, and next thing you know, you got thrombus on it. So in terms of venting that, I probably would have tried a balloon pump first, all right, and inotropes to really crank up that LV and try to get blood flow moving antegrade. If that fails, then I would have proceeded with a LV vent.
I have a question about the 5.5 across the bioprosthetic. For how long do you guys think we can leave it in? So we have had a patient recently transferred to our center. He was in shock somewhere else. He had a bioprosthetic valve. They put a CP on him. They left it in for like, a week. Then the bioprosthetic was toasted, and then, we had to resuscitate him from the shock and also do a big surgery to replace that valve. So do you have a sense, like, would you leave it like for a few days in, or? I
mean, I think that's a theoretical. I think, you've seen it, so it's more than theoretical. I think possibly, if the valve leaflets aren't opening at all, you can get a thrombus across that valve if you have no pulsatility. But I haven't seen it. I try and get it out. I know there's different weaning strategies. I try and use my inotropes, inodilator, and get the device out. I think there's a real, a small but non-zero risk of stroke when you take the device out as well. And, even with the best practices, early anticoagulation at 6 hours, you're still pulling something usually across the arch. And so I try not, although, of course, when we bridge patients to transplant, it's less of a worry, and they're on it for 3 months, but I take it out with the heart. But I try and get the device out as soon as I can, as long as the end organs are intact.
So there was a recent, if I recall, an FDA call-off on Impella for bioprosthetic valves, especially CP. And that became a big issue, that if you have a TAVR patient, probably you will not be allowed to put CP anymore. Is that a concern in 5.5 with bioprosthetic valve? Because that was recently a big issue with all the interventionalists, especially doing TAVRs, that you cannot put that because FDA had called it off. So I don't know if anybody has any idea about that.
I haven't heard about that recall or warning by the FDA. To Marisa's point, even when you put it in, there is always a risk of damaging the valve. We try to, we don't fully unload it, because that way you allow that aortic valve to open and close. I think positioning is key too, because you don't want to pin one of the leaflets, so you got to make sure it's centralized in your aortic valve, and then and you just take it out as soon as you can. So as soon as you see recovery, you start the inotropes and start weaning it. And I've had one in for a couple weeks. I haven't had it more than 4 weeks, I don't recall.
Can I ask you a question about the upfront decision to put a balloon pump? His hemodynamics were okay. He had severe MR, but also had severe AI. So I don't know if actually you helped the patient or you made the hemodynamics worse before the surgery.
That was a situation we did not have options. ECMO with AI would have not worked. Impella would have not worked with MRAI both going on. So at that point, I was like, what, his best option is to go for surgery, and I buy some time to diurize him a little bit. If the surgeon take him right now, that'll be great. But unfortunately, that was not the luxury period. At that time, the surgeon would take him on the same day. So I just put the balloon pump with the thought that I will diurize him aggressively and see next 24 hours I go for surgery. Mainly, it was just for getting into the surgery.
Yeah, I think you can use the 5.5 in severe AI. I mean, I have, and it works. I think the only time you really can't use it is when you have a mechanical valve in the aortic position. I don't know, what do you think?
Even a CP would be just enough to get forward flow to get that patient out of extremis. I think Navin published an early CP experience with that.
Recently we had final comment. I thought it was interesting. Another surgeon did a cabbage at another hospital, and it was a very sick ventricle, and they put a direct Impella 5.5 in. And they didn't have a wire, so you're meant to make the root and the valve incompetent, and so then they can push the device across. But what they did when they did that was they avulsed the right coronary cusp off the aortic valve, but they didn't know it. Anyways, the guy recovers, he looks good. They go to take the Impella 5.5 out. He goes into shock within 48 hours. They didn't pick up what was going on. He sends to us. I didn't know what was going on, except I got a guy, he's in shock after a cabbage. Okay, he needs support. I just took him right to the OR. Lo and behold, on the TE, wide open AI, well, I'm still going to put the 5.5 in as I planned, and then recovered him out of the shock. Took him a day later and replaced his valve, left the 5.5 in, and then he recovered, and now he's home. So I think it's a pretty versatile pump.
Yeah, I won't admit it often, but the interventionalists are right in that regard. When you cross the valve, you should cross with a wire and a pigtail, not a direct. I've seen too many injuries when you try to direct.
Yeah. Any final burning questions or comments? I know that you've got dinner plans or whatever. Well, thanks for staying to the very end.